I want to start with a number that, honestly, it sounds fake. 150 quarts.
Hmm.
That's about 37 gallons. So I want you to picture 37 of those big gallon jugs of milk all lined up.
Right.
That is the amount of blood your kidneys filter every single day.
It sounds impossible, doesn't it?
Yeah.
But that is just the baseline reality of what's happening inside all of us right now.
And yet, be honest, when was the last time you actually thought about your kidneys? Probably never.
Yeah, we don't.
We obsess over our heart rate, we count our steps, we worry about our liver after a night out. But the kidneys, they're just the silent workhorses.
And silent is actually the scary part.
It is, isn't it?
It's the defining feature. We're diving into chronic kidney disease, or CKD, today. And the reason we call it a silent killer isn't, it's not just for dramatic flair.
Right.
It's because the symptoms, they just don't show up until the damage is almost irreversible.
The stats on this are just blowing my mind. We are talking about 37 million American adults.
That's 1 in 7 people.
1 in 7. If you're at a dinner party with 6 friends, statistically, one of you has this.
And here is the kicker, the statistic that actually matters. 90% of those people have absolutely no idea.
Wow.
They're walking around, going to work, feeling, relatively fine, while their kidney function is slowly eroding.
That's the silent part.
Yeah.
It's like driving a car with a major oil leak, but the dashboard light is broken. You just keep driving until the engine seizes.
That's a perfect analogy.
So our mission today is to fix that dashboard. We've got a massive stack of research from the National Kidney Foundation, the CDC, NIDDK, and a really fascinating review on new drug therapies from Frontiers in Medicine. We're going to explain how to actually test for this, debunk some wild myths about kidney stones, and look at a new drug called Finerenone that is it's changing the game for diabetics.
We're going to move way past that high school biology definition of kidneys make urine. That is what, maybe 1% of the story?
Okay, let's start in the engine room then. Anatomically, I think we all kind of know where they are, 2 bean-shaped organs under the ribs. But zoom in for me. What is actually happening in there?
Well, if you put a kidney under a microscope, you'd see about 1 million tiny little units called nephrons.
Nephrons, okay.
These are the workers. And the process they run it's brilliant. It's a 2-step system. First, you have the glomerulus.
The glomerulus. That sounds like a gladiator name.
It sort of acts like one. It's like a very, very aggressive bouncer at a club. It's a filter.
Okay.
It lets the fluid and waste pass through into the kidney, but it blocks the VIPs, your red blood cells and your proteins. Those stay in the bloodstream where they belong.
Okay, so step 1 is just filtration. Keep the good stuff. Dump the fluid.
But if you only did that, you'd dehydrate and die in minutes. That's where step 2 comes in, the tubule.
Alveol.
This is the smart sorter. As that fluid runs down this long tube, the kidney analyzes it, says, wait, we need that sodium back, or hey, grab that calcium, or okay, we have way too much potassium, let's dump that.
So it's pulling things back out of the liquid.
It reabsorbs 99% of the water and nutrients back into your blood, and then it turns that remaining 1% into urine.
See, I think most people view the kidney as like a Brita filter, just a mesh screen that catches dirt. But you're describing a chemical factory.
It is absolutely factory. And this is where the why should I care part really kicks in. The kidneys don't just clean blood, they are endocrine organs. They produce hormones.
This was the part of the research that really surprised me. I never, ever connected kidneys to bones.
Most people don't. But your kidneys activate vitamin D. You can drink all the milk you want, but without your kidneys turning that vitamin D into its active form, your body just can't absorb the calcium from it.
So if your kidneys fail, your bones get weak.
Exactly. It's called mineral and bone disorder. Your body senses it's not getting calcium, so it starts literally stealing it from your own bones to keep your heart beating.
Wow.
And it goes further. Your kidneys produce a hormone called erythropoietin, or EPO.
Wait, EPO, as in the stuff cyclists used to use to cheat in the Tour de France.
The very same. But your body makes it naturally to tell your bone marrow, hey, make more red blood cells.
Ah, okay.
So if your kidney function drops, you stop making EPO, you become anemic, you get tired, short of breath, pale.
So you go to the doctor complaining of fatigue or maybe a fracture, and the root problem is actually the filter in your back.
Precisely. And that's why the silent nature is so dangerous.
Yeah.
By the time you feel that fatigue, you might have already lost a huge amount of function.
Which brings us to, I think, the most critical part of this deep dive, the assessment gap. If 90% of people don't know they have it, are the tests wrong? Or are we just not taking them?
It's not that the tests are wrong, it's that we're looking at the wrong dial. When you go for your annual physical, the doctor usually checks your EGFR.
The estimated glomerular filtration rate.
Right. Think of EGFR as the speedometer of your car. It tells you how fast your kidneys are filtering waste. Anything over 90 is great. Below 60, that's the danger zone. It's a measure of function.
Okay, so if my speedometer says 90, I'm good.
Not necessarily. And this is the trap. You can be driving 90 miles per hour while the engine is on fire. EGFR only drops after significant damage has already occurred. You need to check for the damage itself. You need the leak detector.
This is the UACR test?
Urine albumin creatinine ratio. We're talking about that glomerulus, the bouncer.
The guy keeping the proteins in the club.
Exactly. Albumin is a protein. It belongs in your blood to help build muscle and repair tissue. It should never, ever be in your urine. If albumin is showing up in your urine, it means the bouncer's been knocked out. The filter is damaged.
And the research says you can have a totally normal EGFR, perfect speed, but high UACR.
Yes. And that is the window of opportunity. That's when we can stop the disease.
But the stats on this are they're frustrating.
They are.
One study showed that 82.5% of people with hypertension or diabetes, the people at the highest risk, are not getting the UACR test.
Wait, 82%? These are patients who are already seeing doctors regularly for their diabetes. Why aren't they getting the test? It's a mix of things. Sometimes it's clinical inertia. Doctors are busy and they're focused on the blood sugar or the blood pressure. Sometimes it's just the hassle of asking a patient for a urine sample.
But the result is that we miss the diagnosis.
We miss it until the EGFR starts to crash.
So if you're listening to this and you go to your doctor and they say, hey, your blood work looks great, kidneys are fine, you shouldn't just accept that.
You should ask specifically, did you check my urine for albumin? What is my UACR number? If they haven't done it, push for it.
And what's a good number?
You want that number under 30 milligrams per gram. If it's over 30, you have a leak.
Okay, so that's detection. Now let's talk about who is actually causing the damage. The usual suspects, I'm guessing.
Oh yeah, the big two, diabetes and high blood pressure. They account for 75% of all kidney failure.
How do they actually do the damage? Is it just clogging the filter?
It's a little more violent than that. With diabetes, the excess sugar acts like a slow poison to the tiny blood vessels in the nephron. It causes them to stiffen and narrow. With high blood pressure, I want you to imagine blasting a delicate coffee filter with a fire hose.
Okay, yeah.
The physical pressure just hammers the glomeruli until they scar over. And once they scar, they are dead. They don't grow back.
That's a terrifying image. But
Right.
aside from the big two, I want to touch on something that affects a lot of people. Kidney stones. The prevention advice here was honestly a bit confusing.
It usually is. The calcium paradox trips everyone up.
Right. Most kidney stones are calcium oxalate stones, so logic suggests stop eating calcium.
Right. No calcium stone. Makes sense.
But the research says that is the worst thing you can do.
It sounds completely backward, doesn't it? But you have to look at the gut, not just the kidney. You eat foods with oxalate spinach, nuts, things like that. In your stomach and intestines, the calcium you eat from your diet binds to that oxalate. They stick together. And because they're stuck, they're too big to be absorbed into your blood. So they just pass harmlessly out in your stool.
Okay, so the calcium is like a security guard escorting the oxalate out the back door.
That is a perfect analogy.
Yeah.
But if you stop eating calcium, that oxalate has no security guard. It gets absorbed all by itself into your bloodstream, travels to the kidneys, and since there's no calcium there to stop it, it forms crystals.
So you actually need to eat calcium to prevent calcium stones.
Dietary calcium, yes, about 1,000 to 1,200 milligrams a day. But, and this is a huge but, calcium supplements act differently.
How so?
Taking a concentrated pill can actually increase stone risk. You want it from yogurt, cheese, or milk, not from a bottle.
And hydration. The golden rule.
Dilution is the solution to pollution. You need to be drinking about 2.5 to 3 liters of fluid a day. The goal is to generate at least 2 liters of urine.
Keep the river flowing.
If the river's flowing fast enough, the rocks can't settle.
And the myth about coffee and tea? I've heard they dehydrate you.
Total myth in this context. Coffee and tea are mild diuretics, sure, but they are mostly water. They absolutely count toward your total intake.
Good news for me.
If you love coffee, keep drinking it. Just drink some water too.
Okay, let's move to the kidney kitchen. If you do have CKD or you're trying to prevent it, the diet gets complicated fast. It's not just eat your veggies.
No, it can be quite restrictive. We focus on a nutrient triad. Sodium, potassium, and phosphorus.
Sodium's the obvious one.
It's the universal enemy. It raises blood pressure, which we know damages the filter. But phosphorus is the sneaky one.
The sources made a really big distinction here between organic and inorganic phosphorus. This felt like a crucial aha moment for grocery shopping.
It is. So phosphorus is a mineral that when your kidneys are failing, it builds up in your blood. It pulls calcium from your bones and causes this terrible, deep, under-the-skin itching.
Oh, that sounds awful.
But your body processes phosphorus differently depending on the source.
So if I eat a handful of nuts, that has phosphorus.
Yes, that's organic phosphorus, but it's bound up in the plant fiber. Your body only absorbs maybe 40 to 60% of it. The rest just passes through.
Compare that to, say, a dark cola or a processed frozen dinner.
Now that's inorganic phosphorus. It's used as a preservative or a flavor enhancer, and it is chemically free. Your body absorbs nearly 100% of it.
100%.
It hits your system like a bomb. So the processed stuff is literally more toxic to a kidney patient than the natural stuff, even if the label says the same amount of phosphorus.
So you have to read the ingredients list.
You have to look for anything that starts with PHOS, phosphoric acid, sodium phosphate. If you see that, put it back. That is hidden poison for a compromised kidney.
Then there is potassium. This one is tough because we are all trained that avocados, bananas, tomatoes, these are superfoods.
And they're superfoods for healthy kidneys. But the kidneys are responsible for regulating potassium. If they fail, potassium levels can spike. And high potassium isn't just uncomfortable, it can cause cardiac arrest. It stops the heart.
So suddenly, a banana is a loaded gun.
In the later stages, yes. Patients have to do things like leach their vegetables, soaking potatoes in water to pull the potassium out. And they have to be terrified of salt substitutes. You know those no-salt shakers?
Yeah, for people watching their sodium.
Most of those are made of potassium chloride. So you're swapping a blood pressure risk for a potential heart attack risk. You just have to read the labels.
It really highlights why you need a specialized dietitian. But I want to pivot now. We've talked a lot about the risks, but our source stack included a new review from Frontiers in Medicine about a drug called finerenone.
Yes.
This seems to be the first major breakthrough in a while for diabetics with kidney disease.
It is a massive breakthrough. Yeah. And to understand why, we have to look at the history. For decades, we treated diabetic kidney disease with ACE inhibitors or ARBs, blood pressure meds, and we controlled sugar.
And it helped.
It helped, but people still progressed to kidney failure. We were missing a piece of the puzzle.
Which was what?
We were missing the inflammation and the fibrosis, the scarring. In diabetics, there is a receptor called the mineralocorticoid receptor, or MR. When it gets overactivated, it causes the kidney tissue to get inflamed and turn into scar tissue.
So it's not just pressure bursting the pipes, there is an inflammatory reaction happening in the walls of the pipes.
Exactly. Now, we've had drugs to block this receptor for a long time. Spironolactone is the famous one. It's been around for 50 years.
So why wasn't that the solution?
Because spironolactone is a steroidal drug. Its chemical structure is flat. It looks a lot like other hormones in your body, specifically sex hormones.
Ah, I see where this is going.
Right. So yes, it blocked the kidney receptor, but it also blocked androgen and progesterone receptors.
Which means side effects.
Nasty ones. For men, it caused gynecomastia, painful breast growth. For women, menstrual irregularities. So doctors were hesitant to use it, and patients didn't want to take it.
Enter finerenone, the non-steroidal option.
This is where the chemistry gets really cool. Finerenone has this bulky, three-dimensional structure. Imagine a key that has a giant, weirdly shaped handle. Okay. It fits perfectly into the kidney receptor to shut it down, but because of that bulky shape, it physically cannot fit into the sex hormone receptors.
So it blocks the scarring but leaves your hormones alone?
Precisely. It's highly selective. And the trials, Fidelio and Figaro, they proved it works. They saw a 31% reduction in albuminuria.
So the leak was plugging up.
The leak was plugging up. It significantly lowered the risk of needing dialysis or dying from heart issues.
That is huge. 31% is a game-changing number.
It is. It puts finerenone as a new pillar of treatment. We now have a toolkit. SGLT2 inhibitors to dump sugar, GLP-1s like Ozempic for weight and metabolic control, and now finerenone to stop the scarring.
We're finally attacking the disease from all angles.
We are.
It's so exciting to see the science actually moving the needle.
Yeah.
But we have to address the reality for those where the science didn't arrive in time. Living with kidney failure. We mentioned dialysis earlier, but I feel like people have a very grim, hospital-based view of what that looks like.
That view is, it's outdated, or at least it should be. The standard used to be in-center hemodialysis. You go to a clinic 3 times a week, sit in a chair for 4 hours while a machine cleans your blood.
That sounds exhausting.
It is. It's often described as a part-time job that leaves you completely drained.
But the sources emphasize a big shift toward home dialysis.
This is crucial for quality of life. You have peritoneal dialysis, or PD, which uses the lining of your abdomen to filter blood, often while you sleep. Or you have home hemodialysis.
What's the advantage other than, watching your own TV?
It's the frequency. If you go to a center, you have 2 full days of toxin buildup between your sessions. That's what makes you feel so terrible.
Right.
At home, you can dialyze 5 or 6 times a week for shorter periods. It mimics the natural kidney much better. This means fewer dietary restrictions. You can eat that banana, and you just have way more energy.
It sounds like reclaiming some autonomy.
That's the word, autonomy.
Mm-hmm.
And that connects directly to the mental health aspect. The NKF data shows that 20 to 40% of kidney patients suffer from depression.
That's a heartbreaking statistic, but it makes sense. You're grieving your health, your diet is restricted, your schedule is controlled by a machine.
That's a loss of self.
Mm-hmm.
And often, nephrologists are so focused on the creatinine and potassium numbers that they forget the human. But treating the mind is part of treating the organ.
Because if you're depressed,
you aren't going to take your binders, you aren't going to stick to the fluid limits, it all falls apart.
So the support systems, like NKF peers, they aren't just nice to have, they are medical necessities.
Absolutely. Peer support. Talking to someone who has actually lived through the dialysis transition, that's more valuable than any pamphlet a doctor can give you.
So we've covered the silent anatomy, the 2 essential tests, the dietary minefield, and the new science. It feels like the big takeaway here is connectivity.
That is the word of the day. In medicine, we love our silos.
We do.
You have a cardiologist for the heart, an endocrinologist for the diabetes, a nephrologist for the kidneys. And they rarely talk to each other.
But the body doesn't work in silos.
Not at all. Look at the drugs we just discussed. Finerenone protects the kidney and the heart. SGLT2 inhibitors treat diabetes and protect the kidney and help with heart failure.
It's all one system.
We are starting to use the term cardiorenal metabolic syndrome. The data proves that treating the kidney is treating the heart. If you protect one, you protect the other.
So the final thought for you, the listener, isn't just check your kidneys, it's check your system.
Exactly. We need to stop waiting for the engine light to come on.
So here is your homework. Next time you're at the doctor, don't just nod along. Ask for the leak detector. Ask, what is my UACR? It might be the most important question you ask this year.
It could save your life.
Thanks for diving deep with us today. Take care of your filters.
Stay healthy.